And now I'm going to pass the microphone to Dmitry Raspirity to present the next clinical case. We're going to have one more case before we break for coffee, and we are ready for translation from this operating room. So the next case is different. It's going to be not a norm, but some anatomic abnormality.
So the second presentation is about pancreatology. That's a disease of pancreas. And I'd like to introduce here a patient, a man of 54 years of age. Their first attack of the disease was in August this year, as an acute pancreatitis. He was treated as outpatient in outpatient mode in another clinic with positive results. And in this clinic, the ultrasound showed pancreatic mass. Then a patient appeared in our clinic. Here you see lab tests. And you see a moderate elevation of blood amylase, with other indices being normal, and a spiral CT in September showed the cyst lesion in the body with narrow pancreatic duct, and also signs of thrombosis of upper superior mesenteric vein with infiltration of parapancreatic fat. At the moment, a patient is considered as a patient with pancreatic mass, and the extent of manipulation is as follows. We're going to do EUS, diagnostic EUS, to assess the pancreas and surrounding tissues, and to see if there are indications for FNA. And main task for ours is differential diagnosis of local lesion. So it's a cyst or solid mass. It's a cyst lesion. It's a cystic lesion. But what was it? IPMN, mucinous, or something like that. It's just a cystic lesion, and that's it. Well, it's said like that because we don't know what is that. Since we don't know what is that, we decided to do EUS. So don't we know? Don't we have any other diagnostic material from those methods that were used? No. The final conclusion, final diagnosis before the procedure was said as just a cystic lesion. But where was it done? Not in our clinic. That's one very specific feature. That's why I'm showing this patient as a patient appeared in ours. So majority of patients are not from our clinic. We collected them from all over the city. So there could be real life settings. The question is not into the mic. I'm sorry.
Думаю, что стремление набрать профильных пациентов здесь немножечко.
So the idea to collect appropriate patients, we did want to have the appropriate patients. That's why we weren't able to repeat those testing. And you can see it in my questions, because that interpretation on the basis of those really high-level expert methods is not enough. We could consider it as a not sufficient diagnostic routine, not qualitatively. So, but that's real-life settings. It's reports of our imaging specialists. So let's try to see how can we resolve the issues of insufficient diagnostic, of low-level diagnostic solutions. So how can we resolve the situation? How can we help such patients using EUS? So let's see if our colleagues can manage successfully this really complicated task.
Welcome back. So I have to thank the team, the anesthesiologist and the nurse for the good job they have done. So the patient is has acute pancreatitis 2 months ago, and he has a CT done 2 months ago that shows a lesion in the body of the pancreas. So we're going to start the examination from the duodenum. So we are already down into the duodenum. We fill up the duodenum with water. If you can give me the US image. Can you show the US image?
Переключите, пожалуйста, на ультразвуковой. О, прекрасно.
Okay, perfect. So we are in the duodenum. As you can see, the duodenum is filled with water. So air is an enemy of the ultrasound. So it's to investigate the duodenum area, it's important to fill up the lumen with water. We are using a UCT 140, so this is a therapeutic scope with a 3.7 working channel that allows you to put a needle very easily. You can put a small needle, but also a large needle. Before we use a P-scope, that is a diagnostic scope that does really not allow you to use a large needle or to do therapies if you do, for example, pseudocyst drainage. So at this point we are at the level of the papilla. We see a lot of small rounded black structures that, in my opinion, these are vessels. So we can put the Doppler. So these are vessels. So it means that probably this guy has had multiple episodes of acute pancreatitis. I don't know if he has a history of drinking, and the pancreatic parenchyma is a little bit. It's all
not a little
bit, a lot. It's really dishomogeneous with lobularity, so it looks like a patient with chronic pancreatitis. You can see a very small CBD bile duct. Look at the bile duct. How small is the bile duct? So we follow the bile duct up to the portal vein and to the ileum, where you see there are these are vessels, and this is the bile duct. So there's not really, the bile duct can be followed up to the papilla area. So what you see afterwards is a dishomogeneous tissue that, because of the duct is normal, this is probably most likely an inflammatory process that involves also the wall of the duodenum. So this is, you see the wall of the duodenum is all thickened, and this occurs in acute pancreatitis or in patients who has recurrent acute pancreatitis or who have, for example, who drinks too much. So we are coming back. So this is the pancreatic duct that probably dilates into a fluid collection that measures how big it is, this one. So this is the pancreatic neck. We are going to go and see. So it's about 2 centimeters. So it's 2 by 3 centimeters. And there's not really a lesion, but there is some material inside. So this is probably an inflammatory collection with some necrotic material. So this is probably a consequence of the pancreatitis, not the cause.
Let's show.
So this is a lymph nodes. There's a lymph nodes, big lymph nodes. Let's see if there's any flow inside, because sometimes there are also aneurysms that can basically mimic a fluid collection, and then if you put a needle, it can be very painful. So, and actually, you see, we start seeing a much bigger collection on the left side that is in a connection with the pancreatic duct. So this is something we have not seen.
Let's measure and then try to
Yes.
find the connection.
So we are talking about something that is around 80 by 8 by 5 centimeters that probably can be seen much better from the stomach. So we're going to go back to the stomach. So we can see a little bit of ascites. So this is, for example, is important for also staging of pancreatic cancer because, or gastric cancer, or because the presence of small volume ascites is usually associated with the metastasis in the peritoneum, or mental metastasis.
Maybe it's one thing that helps us to differentiate the malignant and benign.
Yes.
And if you take biopsy, take
Yes.
fluid.
So this is the small collection that we have seen before. So you see that there is some material inside. These are not neural nodules. It looks more necrotic tissue. So this is probably a consequence. So that the wall is thickened.
There is no flow.
There's no flow. So this is might be the pancreatic duct, small in this side. Let's see if we can trace this one. Okay, so this is some calcification. So the pancreatic parenchyma is atrophic. It's not very well recognizable as, if you compare with the exam before where we can see the parenchyma very well. Here it's atrophic, there's a lot of calcification here, and here there is we lost it. So there's a connection with this, you see.
Maybe there is a connection between two fluids,
With
but,
two fluid
but
collection.
not with the pancreatic duct.
Sometimes with the pancreatic duct is difficult too, because I think this is probably an area also of some degree of pancreatitis also. Mm-hmm. But clearly there is this lesion that in some way it's connected to this other bigger lesion. So we don't know if. Okay, so let me see. Okay, so this is probably a pancreatic pseudocyst.
What do you think about the wall of the cyst? Do we need to measure it? Do we need to examine?
So I think what is important is, so this was not there 2 months ago, okay? So this means that something happened, and this is an evolution of the episode he has 2 months ago. So this is basically a consequence of his acute pancreatitis. What is important to me is to find out if first, if there is a necrotic material inside. Because if you have a lot of necrotic material inside, what I now do is I place a metal stent, I get inside, and I do necrosectomy. I'll show you a video in the presentation later on. While if you just have fluid content, probably you just, it's much cheaper and effective to place a plastic stent. And for example, it's important to establish if there is a connection with the pancreatic duct or not, because if there is a connection, you need to leave the plastic stents forever. Because if you take it out, there's a 30% recurrence rate after you take out the stents. These are data from Belgium, from the Viers group in Brussels. So I think what I would do now, we can eventually puncture get some fluid, see the color. So if it's white, it's pancreatic juice. Means that this collection is in connection with the pancreatic ductal system. If it's brown, means that is not. And then we can decide what to do in terms of planning a therapy. So we can decide if this patient is symptomatic, if he needs this collection to be drained or not.
First of all, can we use here Atlanta classification of this cyst?
Yes, this is a pseudocyst. So in Atlanta, the revised criteria, there's a classification in 4 entities that are pancreatic pseudocyst, acute pancreatic fluid collection, where basically the wall is not formed yet. And for example, we have a series in which we started treating these patients, even though it's not recommended, but sometimes there are very sick patients who are at very high risk for surgery, so we start treating this patient too. And then there is acute necrotic collection, or abscess, and then there is the WOPN, so the walled off pancreatic necrosis, where basically you have tissue, necrotic tissue inside the lesion, and I think that these are the most difficult one to treat, especially when there is a very high component of necrotic tissue. And the debate now for this type of lesion, especially for walled off pancreatic necrosis, is which stent to use, because usually until recently, they always used the plastic stents to drain this collection, and the plastic stents can become occluded. So there's a risk of super infection. There's a risk to need to repeat the procedure and failure. So there's a technique developed by Varadarayulu that is the gateway multiple gateway technique, where he basically place plastic stents in multiple places. So it does 2 or 3 accesses, and then leave nasocystic drainage, so you can lavage everything. And the problem of this technique, I think, is basically has been reported only by him. It's a kind of cumbersome, and the hospital stay of the patient is pretty long, because the median hospital stay is 16.5 days. So we just have accepted 4 cases where we use a new metal stent that is a stent that can be placed by US guidance. Is an Axios stent, is an American company. And what we do, then we dilate the tract, and we go inside, and then we use hydrogen peroxidase to melt down the tissue and to help out cleaning all the material, and we had a pretty good results. And I just also finished to collect the European experience using these metal stents for collection, and I will present the data later on.
And how do you want to examine the fluid? Only according to visual sign of pancreatic fluid? And
I think in this case, this guy has an acute pancreatitis 2 months ago, so the chance that this is a cystic neoplasia is very low. So this, to me, because of the clinical history, is a pseudocyst.
That means we don't need to use such kind of CAA and CA19.
In this case, I would not do it. Unless the fluid is kind of strange. I think the clinical history is clear. There was nothing 2 months ago. Now there is a collection, so this is an inflammatory collection that was caused by the previous episode of acute pancreatitis. I think it's different if you have, for example, a lady who comes in and
young lady,
or also not a young lady, but somebody who does not have a history of acute pancreatitis, who come with a collection. I think is very important before doing the drainage procedure to make sure that you are not dealing with a cystic neoplasia.
And last questions. Can we give precise diagnosis after EUS? Because after EUS we discussed about some cystic lesion. Can you give us a precise diagnosis?
So the cystic lesion is a gray area.
Yes.
So it's not 100%. I think in this case it's clear because we have a clinical history, we have an exam, a CT 2 months ago that was normal, but sometimes it's not easy to arrive to a definitive diagnosis. So I think it's sort of a puzzle. So you put together the imaging, the clinical history, the patient age, where the lesion is, the CA, the amylase, and you try to get an answer. Sometimes you don't get an answer.
And if everything is so clear, do we need to perform EOS-FNA?
In this case, no, but in this case, I would just do to see if it's clear or not. So if it's clear, we know that if we need an intervention, we need to place plastic stents, probably a couple of plastic stents, because it's better than one, and to leave them forever. So I think we can just also to see the liquids and show them what can be one or the other.
Okay, let's do.
Yes. Can we give antibiotics before?
Можно сейчас антибиотики дать? Внутривенно.
Can we give IV antibiotics?
A word about this type of needle. And
So this is an Olympus needle. It's the shot 2, number 2, right?
no, not shot. It's a shot 1.
Easy shot 1. Okay, easy shot 1. So I have the updated version. There's actually this is a 22 gauge needle. We are doing a study now with there's a new version with a lateral opening, 22 that can also be used to get tissue. It's out of the instrument. Let's see if it's out. Okay, it's out from the instrument, so we are not going to puncture the instrument. It's always important to make sure that the needle is out. So we retract a little bit the stylet. Doesn't come out. Okay, so the needle is out. You can leave it the scope, it's okay. I usually perform without the stylet, so I already put the syringe inside. So at this point we are inside the collection, we take out the stylet and we put a 20 ml syringe. Let's see what's come out. So this is purulent material. Not purulent, but it's kind of a necrotic, and in fact, if you see, there's some debris inside. You see, it's not completely black, so it's not completely fluid. There's some debris inside, so I think this tells you that it's probably not connected to the duct,
yes.
but you have debris inside. So if you want to treat, probably the best way is to place
metallic stent
or metallic stent or two plastic stent.
Two plastic. Yes.
So I think we have what we need. So when is it? This is a. You can show the color. So this is clearly not pancreatic fluid. Pancreatic fluid is basically has no color, it's whitish, transparent. So this it's really necrotic tissue that has colliquated, and there's not really a clear-cut connection with the duct. So usually when I puncture any cystic lesion, any fluid lesion, I give antibiotics. It's a prophylactic measurement, then you don't need to give any more, and there's never been proved that it's really working, but you know, one dose of antibiotics is better than having an infected cyst, then they become an emergency.
Maybe
Do you have any question?
Yes, maybe this is time for discussion.
Yes, we have a question. If there is any suspicion of connection with the pancreatic duct, is it possible to place the stent in the pancreatic duct in order to prevent recurrence of the cyst?
This is something. So before US guided drainage, a lot of these cases were treated with the ERCP, where they were placing a pancreatic duct stent. I think that nowadays, unless you have a recurrence after place the stent and treat the pseudocyst, it's not necessary to place a plastic stent into the pancreatic duct. If the lesion recurs, probably at that point you need to do a sphincterotomy and place also a stent in the pancreatic duct. But nowadays, I think with the US, the advantages of US are, I don't know if we have the endoscopic image. I didn't see if there is any bulging, but you can approach non-bulging lesion. So sometimes you don't see the bulging in the stomach. So basically, if you do endoscopically, it's a blind puncture, so it's dangerous. You can avoid vessels. And I think one of the most important things is also what we have shown. You can basically assess the content of the collection and then make a plan based on what you see. Because sometimes you have a CT, an MRI that tells you that is a pseudocyst, and then you do a US, and there's a lot of necrotic tissue that change you what you're gonna do. So I think US is more is better to assess really what you are dealing with and to make a plan as a consequence of what you see.
If there is a connection between cyst and pancreatic duct, can we treat pancreatic cyst only by placing pancreatic stent?
I actually prefer to place stent in the collection.
In the collection.
Yes, because then what you're going to do. You're going to leave the stent forever.
Yes.
Then you're going to have stenosis of the pancreatic duct. So I think if you place the stent between the collection and the stomach. It does not cause complications because it can stay there forever and there's no problems. While if you place a plastic stent in the pancreatic duct, you can have strictures, you can have inflammatory reaction, and you can have problems that you don't have by placing transmurally.
Уважаемые коллеги, есть ли еще вопросы в зале?
Colleagues, are there any questions? Please take a microphone. Да, хотел спросить, если проводите стентирование этой кисты, вы введете один стент или два стента?
You can place one 10 French or two 7 8.5 French, double pigtail.
Yeah, and do you have usually opportunities to perform cystography during this procedure? Cystography by contrast enhance. Контрастирование кисты. Contrast by X-ray.
I don't think you need to inject contrast. You just need to do in the fluoroscopy room to see the guide wire and to see the placement of the stent. Actually, with the metal stent that you can follow by US, I actually do the procedure in the US room without fluoroscopy.
Thank you.
I also drain the gallbladder without fluoroscopy. I'll show you some video later.
You are very brave.
No, it's a different. You know, we are doing some of the procedure, interventional procedure that we are doing. We are doing using the accessory of ERCP that probably are not the right accessory for US guided procedure.
Да, уважаемые коллеги, на самом деле вот я знаю, как работает Альберто Ларги, и если у нас в России
Colleagues, I know how Alberto works, and if in Russia there is a situation when our colleagues they do RCP without X-rays, then Alberto he's doing draining manipulations without any X-rays, without fluoroscopy, only using EUs. It is really possible.
A question, please.
Можно вопрос? Скажи,
I would like to ask a question in this clinical settings. Maybe we should study the liquid we obtain to see the amylase concentration, to understand if it's a true pseudocyst, if its amount is more than 1,000 units, or if there is no amylase, it allows us to exclude completely the pseudocyst.
I think in this case, I think it's clear that this is an inflammatory lesion as a consequence of the acute pancreatitis that he had 2 months before, because 2 months on the CT there was nothing, right? So he had an acute pancreatitis, he had a CT, this lesion, this collection was not there, so this is a consequence of acute pancreatitis. So I think you don't really need to measure this the CA and the amylase in the fluid, because you know that this is a pseudocyst or is a collection as a consequence of the acute pancreatitis. Differently, if you have a patient who has abdominal pain, mild abdominal pain, who does a CT or an MRI and find a 5, 6, 7, 8 centimeter lesion, you need to exclude a neoplasia, because at that point you are not going to drain a cystic neoplasia, but you're going to send the patient to surgery. So in that case, what I do, I bring the patient, I get fluid, I analyze, I send for CA and amylase, and then if the fluid and everything prove that this is a pseudocyst, I drain them. Otherwise, I send to surgery. And if I'm not sure, I don't drain collection that I'm not sure that are inflammatory collection, because if you place a stent in a patient who has a neoplastic cystic lesion, you can make a big mistake.
спасибо.
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 Уважаемые коллеги,
Thank you. Any more questions? It's quite an interesting situation. A patient who developed, we don't know nothing. If we don't know what to do, we can do the procedures, the EUS, to have the complete set of information, and all further steps are quite clear.